नमस्कार, कैसे हो भैया?
बढ़िया बढ़िया।
Okay, sir.
Yes.
अहमदाबाद.
Good evening, sir. Amit this side. Amit Arora.
Parth,
Amit,
kindly make me co-host for the program, and we are starting now. Okay?
Yes, sir.
Okay. Good evening, friends. Welcome to this 100th edition of the PG Tech program of Delhi CSI. And I have great privilege and honor to be here in front of you, because it's been a long journey, and it was only because of COVID that this idea was suggested by our seniors in Delhi CSI, and we conceived this particular program, and now it has been a long way, and it is probably one of the most consistent and the longest running academic series of cardiology program ever. So today we are into the 100th webinar. I have the great privilege of having Professor S.S. Kothari, who will be speaking today on the role of clinical evaluation in the era of technology, And along with this, we have our respected Dr. K.C. Goswami, sir. We have respected Dr. Sanjay Tyagi, sir. We have Dr. Suday Kumar, sir. We have our respected Dr. Rakesh Yadav, sir. My colleague, Dr. Girish MP, and Dr. Suman Mandari, sir, who is president of Delhi CSI. So I would request Dr. Rakesh Yadav to say a few words about this particular program. I would also request Dr. Goswami, sir, to say a few words, and then we will start the program. And we have Dr. Suman Mandari, sir, who's also going to speak a little about this program. Very few words. Rakesh, sir, over to you, please.
Thank you, Mohit. And I think it is my privilege, and I should really thank Dr. Mohit that he has worked hard to give this 100th edition of this program. And this program is really about 300 to 400. I think it is more sometime that the PGs are listening this program, because practically all the lectures are being taken by all the doyen of cardiology. And when it was thought that to whom we should call on 100th episode, so that we have all unanimously decided that it should be only Dr. Kothari that should be called for this 100th, because it's a great achievement. And it's all inspiration of all our seniors. Dr. Goswami has inspired us that you should start it, and we have started it. Dr. Suman Mandari has always been absolutely great supporter of this type of event. And every time he also said that why you are not doing it. Say thank you, everybody. Thank you, Dr. Tyagi, sir. And I think I will request Dr. Goswami to say a few words.
Thank you, Mohit. Thank you, Rakesh. I welcome my dear friend, Professor Kothari, to give oration and lecture, whatever he want to do it on the 100th series of this webinar to teach our lovely students. So over to Kothari. Thank you.
My compliments to Dr. Mohit for completing the century.
Suman, sir. So please unmute yourself, sir.
I think it's a wonderful feeling to have this 100th episode, which Mohit and all my predecessors and CSI have envisaged, and it's a very successful evening to have Dr. Kothari actually give us this address, and I think I would like to thank him on behalf of Delhi CSI to take this talk forward. Thank you, Dr. Kothari.
A word by Dr. Suday, sir, who has been with us for a long time. Suday, sir, please.
It's a pleasure to be with you all. Thanks for giving me the opportunity to join you for the academic activities and participate in the Century program. Thank you so much. Really enjoying that. Okay.
Thank you, sir. And thank you, Amit, for providing us a great platform for this academic support for almost 2 years now, and we are still continuing. So we would not be standing in front of you between your academics and Dr. Kothari, and let us straight away go invite our respected Dr. Kothari to speak on the role of clinical evaluation in the era of technology. Over to you, sir. You can share yours.
Good evening all. Today is not a day for lecture, it's a day for joy. Completing 100 such session is a wonderful thing. It's all kudos to Delhi CSI, kudos to Dr. Bhandari, Dr. Mohit, all the CSI people. Dr. Mohit in particular, who has been really spearheading this movement sort of thing. It is nothing short of a movement. And actually, I'm so joyful that you called me. 100th occasion is the occasion for joy, and I don't intend to really give you lecture in that sense. So I'll be sharing some of my feeling. I am going to talk to you about what I think is happening and what we think, what should be looking for in terms of patient care. So with due respect to all my friends and colleagues in panel, Dr. Sudhir Kumar, Dr. Suman Bhandari, Dr. Goswami, my dear friend Rakesh, and Dr. Tyagi, I'm going on. So let us start. I hope people will join. So
Yes,
let us, you know, when life was simple, they used to say art is long, life is short, opportunity is fleeting, experiment dangerous, and judgment is difficult. Now you might wonder that those judgments were difficult when there was no technology. And poor Hippocrates, without ECG, echo, X-ray, what could he have been doing? But simple as it sounds, the statement is even more relevant today. And I will show you in course of time why it is so. We have come a long way in terms of technology from this to this. And the master clinician Osler observed that you must observe, record, tabulate, communicate. Use your 5 senses. Learn to see, learn to hear, feel, smell. And by practice alone, you can become perfect. You can become an expert. Now today, young boys might be asking, is there an evidence that it works? Do we really need all this? We are having artificial intelligence and we are having a car which can be moved even without looking or seeing. So there is a situation where we have reached this far. We don't need to use our eyes and ears and hands, but if we have it, why don't we use it? Why won't we use common sense? Why won't we use the things that we have instead of relying entirely on technology? And why won't we ask our patient, you know what is happening? Technology is very powerful. Technology has made demystified diseases and has made treatment as never before. We have made tremendous progress and we cannot live without technology. But in the din of technology, in all the brouhaha of IVUS and ROTA and ECHO and FFR, we have forgotten a simple thing. We have forgotten to ask the patient, what ails you? Why are you here? And that is where we need clinical evaluation despite all this. Our eyes do not see unless the mind knows. So what is clinical evaluation? Clinical evaluation includes history, physical examination, clinical thinking. And as mature doctors, I am addressing fellows who have already been postgraduates, you would recognize that it is not only history and physical examination, but it is the context generation. Everything has a context. And the most difficult thing is the context generation. Unless you generate the right context by history, physical examination, and by clinical thinking, no amount of technology is going to help us. And as they say, you know, right diagnosis is 3/4 of the remedy. If you understand the problem right, if you understand our patient right, then rest of it is just the course of action, you know, just a kind of follow-up. So clinical evaluation is essentially knowing thy patient, and it incorporates all that is unique about the particular subject in a particular situation. Why do we still need clinical evaluation? Because we are not robots. Our patients are not robots. Our resources are not infinite. And we are professionals. We would like to do a thing professionally. And professional thing means getting it right with minimal discomfort to our patients, with minimal cost to them. Patients trust us to do our best. And practicing medicine without clinical evaluation is not only idiotic, it is almost sinful. Practicing it without clinical evaluation is not idiotic, it is even sinful. Sometimes we used to think that doctors exist for patients. Doctors are there to help patients to lead their better lives. And it seems nowadays that patients are there for doctors to lead better lives. That is what technology has done to our profession. And that is why there is so much of distrust, and we must fight that. It is often said that we must keep patient best interest as the top priority. No, it is not the top priority. It is the only priority. The patient's best interest is the only interest. And this is a thematic statement of the Mayo Clinic when it started. And I think it is worth remembering that that is the way medicine has to be practiced. Treating patients without clinical evaluation is like boarding a bullet train. You know, only difference is that it is going to Mumbai when you really wanted to go to Delhi. So that is what clinical evaluation will do to get you to the right train. And technology will really take you very far quickly on that. And I will illustrate my point with some clinical examples. And I hope you will learn a few things by going through those cases. The next few minutes, whatever we have, it's all about cases and about the importance of clinical evaluation. Now, I I'm missing students in front of me who could have interacted, but I'm taking that they are there. So, okay, there is a 30-year-old man who had a bronchoprosthesis and he came with worsening dyspnea, and you can see there is a high gradient in mitral valve. So the gradients are reaching up to 15, 16 and is significantly dyspneic. And something is done by which this thing has settled down. Mitral valve has become better, the prosthetic thickened valve has become thin. And it is neither surgery nor thrombolytic therapy. Can you imagine what it could be? And that is the power of clinical evaluation. This patient had eosinophilia, he was treated with steroids, and everything settled down without thrombolytic therapy. And if you did not believe me, I will show you another patient. This is a 17-year-old girl, had 3 episodes of PHVT in 2 years. And one of them, the valve was replaced, thrombectomy was done. So she needed open heart also. And in all the 3 episodes, there was eosinophilia, which was missed up to 30%, because the treating physicians at that point in time did not recognize that eosinophilia could be cause of prosthetic valve thrombosis, even with a normal INR. Completely missed. And we reported this in BMJ as a misdiagnosis and learning from errors. Yes, the good thing in our profession is that we will keep learning no matter what age. But yes, as you become age like us and all my panelists, we will be talking of the past of what we have seen. So some of these are old stories, bear with that, but I'm sure it is going to be educative. Another 30-year-old man came with chest pain for 3 hours and has ST elevation in anterior lead, stroke positive, run of the mill. It's just that he's young. But nowadays, getting MI in 20s and 30s is nothing unusual. So this patient was brought to me that something is not looking right, and this is his echo. So this is about 12 years old story with that ST elevation, drop positivity, and some pain which is lasting for 3-4 hours, 5 hours, little more. So I diagnosed this as a myocarditis. This hypertrophy was because of edema, and after 4 weeks, this is the repeat echo. Hypertrophy has settled down. Of course, coronaries were normal. So if you put everything together, you can avoid some misdiagnosis. Very recently, this is a 15-year-old boy, complete heart block, inferior MI, 15-year-old. And a history of fever for 4 days. So this is a little murky. This is his echo. Bit of a pericardial effusion, bit of the thickening. And you can sense that, and nowadays we know myocarditis can masquerade, but it can really mimic totally. And in this particular patient, although COVID was negative, but it seemed that he actually had infarct. His MRI showed transmural scar and a dilated circumflex, which means that he really had MI also. So such a patient, should he be thrombolized? He was thrombolized outside. Maybe it was right under the circumstances. So total evaluation will guide you better. I'm not saying you should do this or do that, but you should evaluate the patient totally. All right. Much more interesting things to follow. 60-year-old lady, courtesy Dr. Narang's patient. She had 4 episodes of syncope, and outside this ECG was recorded. When she came to us, she was in dire state, in shock. You can see the X-ray. And this is the look of the patient. Now, the smart thing is, with this look, what do you think? You saw those VTs, and this is the patient. Now, this patient had known hypothyroidism. And the hypothyroid patient, TSH was done, which was low. So the thyroxine was stopped because the TSH was low. That is the medicine without clinical evaluation. And she went into myxedema coma. This carotenemia is a sign that she was in myxedema, gross myxedema. And actually the story was that 30 years ago, she had after delivery, severe postpartum hemorrhage and Sheehan syndrome. She had Sheehan syndrome, absent pituitary. And once that thing was put on track because of the recognition of carotenemia, myxedema coma, steroids and everything else, she responded well. To cut the long story short, this is the patient after the proper treatment of Sheehan syndrome. And the clue was the carotenemia. Otherwise, no amount of MRI will give you the thing that you need. This is from Dr. Amboj and Dr. Shrenik, another severe cardiomyopathy patient. You can see M mode. I don't have a running picture because this is also a little old story. And this is the lady's face. And a bright resident came up with the story that she had a lactational failure following last delivery 20 years back, another Sheehan syndrome, another fantastic response. Can you believe this? Dilated cardiomyopathy. This is the heart. This is the echo. And unless you recognize the right thing, no amount of Vyamada or dapagliflozin or evidence-based guideline-based directed therapy will help. So I'm not saying don't do guideline-based therapy, but don't parrot that. Get into the patient, know thy patient. That is the message. Well, 32-year-old man with TIA. Poor heart, cardiomyopathy, had a stroke. You can see the thrombus. And here is the patient. It's a real story. obviously, your suspicion is right. But it is not steroid induced. He did not agree. He was using mephenteramine, entirely new novel finding of mephenteramine induced cardiomyopathy, not previously reported. Once he stopped mephenteramine, the LV became better. And he would not agree normally. So I had to take him to the side, and Dr. Gautam, his friend to him, and he agreed finally that yes, he has been taking mephenteramine shots, and then mephenteramine stopped and he's become better. Unfortunately, left again. And then later on, I do not know what happened to him, but we have diagnosed it correctly. Patient with restrictive cardiomyopathy, and just a small dot, and Fabry's disease is diagnosed by dermatologist. Later on, he was put on enzyme replacement therapy. I have not personally seen this patient. So you might argue that we are cardiologists. We cannot do dermatology and psychology and gynecology and know everything. That is true. But as a physician, what you can do is you can recognize what is important and what is not important. In a patient like this, if you just ask what is the story, and if he gives a story of pain, aches all over, burning feet, failure of sweating, family history of similar illness, and some odd-looking lesions, you should have vision to recognize and take some opinion from dermatologist. I myself would not know Fabry nodule, how does it look like? But I think I would see this thing and ask the patient, to ask some resident, okay, let us take a dermatology opinion. Could this be something different? Could this be something be relevant? Very often you will find incidental eczema, incidental pemphigus, not relevant to cardiomyopathy. But it is well worth keeping in mind that we have to know the patient. We have to keep the patient in the center. This is a very recent story, about 6 months old, and some of you might have seen this. This was Dr. Bhupati from Chennai, and Dr. Sivaramakrishnan gave this patient, and we discussed this patient in some other forum. This patient had severe MR. She's 82-year-old, came with terrible heart failure, had severe MR. So they thought of doing mitral clip, and they were, I think, affording. So a call was sent to US, and mitral clip things were arranged. And when they again reorganized the patient, the MR has disappeared. So severe MR has become mild MR or no MR. And because the pressures at that time, PA pressure was 80, systemic pressure was 220. So when the systemic pressure became normal, the MR disappeared. Did not need mitral clip. But it's a long story. Then she, as soon as the pressure were controlled, she went into renal failure. She was intubated. She would not come out of the ventilator. And these physicians, fantastic people, they just become suspicious that this is not fitting with the usual story. So that a cart was normal, but that was done from radial. So this time they thought that with this much pressure, kidney failure has gone. Renal artery Doppler was normal, but Bhupati and Manoj will not leave that. And they catheterize the patient, and they recognize there is a gradient, significant gradient. And ultimately, the CT showed a coral reef aorta, calcific acquired coarctation. Very few people might have heard of this. Coral reef aorta was 3 millimeter at some point in time. It was tackled interventional cardiology, high flow technology. Everything was done, lithotripsy and IVL, God knows what. But patient finally made it fantastically because they got it right. And kudos to them because they did not give up. And they recognized the anomalies in the approach. And it also demonstrated the low dependency of mitral regurgitation, which you should keep in mind. All right. Coming back to a bit of younger fellow, you saw 80-year-old. Now you let us have a look at the neonate. A neonate is born who is blue and is AST right to left. So pediatrician will diagnose structurally heart is normal. Structurally heart is normal, AST is shunting right to left. So it's a persistent fetal circulation. So when there is a persistent fetal circulation, AST shunts right to left and the babies are blue. So that's okay. So when I saw this patient, but his pulses are bounding. And he's not in so much distress. A PFC patient pulse will not bound. Pulse will be thready, small, low output. This was a large bounding pulse. So you do an echo, structurally normal heart. Echo shows aortic runoff, but heart is normal. And what you have is vein of Galen malformation. In fact, when you see this story and you tell you that one of your colleagues has seen echo, it is normal. I put the stethoscope on the skull and the murmur there will tell me that this is a vein of Galen malformation. One cause of aortic runoff when the heart is normal. So it was vein of Galen and subsequently treated like that. This story is about 15 years old or more, so I don't have a full data on this. But once you've seen this, you will probably never miss. This patient, 10-year-old, was taken for surgery for mediastinal tumor. The lateral X-ray showed a mediastinal tumor. But the anesthetist, while on operation, this is outside, he recognized the baby is blue. So he did not let the people operate and send it to us. When we saw this patient, this shadow, I have seen many, so I know this shadow. Heart is structurally normal, patient is very blue, and this is RPA to LA. And this is unmistakable shadow of RPA to LA. If you see few, you will recognize. And subsequently, this was picked up, diagnosed, and we devised it. One of the early record of those devices in the SCATS DVD. with Dr. Ramakrishnan. So just keeping the patient in totality gave us the right diagnosis. Now this is a child and the saturation is 85%. Any diagnosis? If you were alive, it would have been fantastic. But you see, if a baby is 85, this is little old and is not blue, then this is methemoglobin. Significant cyanosis without clubbing is methemoglobin. So it was, and that's it. Now you have a patient with RSD-MR and you see this, patient has known case of RSD-MR, but if there is nodules, then this is active carditis. You have angina, chest pain, and these are the nodules, then it is a familial hypercholesterolemia or a supravalvular aortic stenosis. It is a familial hypercholesterolemia. These are all real patients. And there is a graduate of JNU and getting, inexplicable neurological symptoms, paraplegia, quadriplegia, and then it becomes all right, occasional. And everybody is surprised at what is happening. And only if you had the heart to recognize that she's maybe minimally blue and there is a hereditary hemorrhagic telangiectasia, she's having pulmonary fistula. But for practicing clinical evolution, we have to have theoretical knowledge, and the application of that knowledge. That knowledge tells us that in people with pulmonary fistula, you can get inexplicable neurological symptoms because of from right to left shunts. So this lady had paraplegia from pulmonary fistula, and the fistulas were tackled, and then things settled down. But the diagnosis came from picking up of this thing, and then also knowing that contrast echo in a minimally blue patient. This is obviously Eisenmenger PDA. Differential cyanosis, nothing much, but PDAs could be different also. This is a PDA of last 2 years. Patient had a continuous murmur, and I had a PDA and taken for a device closure of PDA. But before that, Dr. Saurabh Gupta saw that these two hands are, what is the point? Right hand is a little thicker than the left hand, and he got suspicious. And you know him, he won't leave it like that. So next thing he went was, got a CT done, and the CT showed something fantastically remarkable. The left brachiocephalic is not coming from aorta, it is connected to PA. Left brachiocephalic is connected to PA that is looking like a PDA, and actually the patient has a disconnection of innominate from the brain. So the left hand is getting less blood supply, it is thinner. And we have seen 2 cases like this where subtle clinical signs were there of a disconnected artery, and subsequent course is a bit of a tricky thing, little long story. But it was not a PDA, and if somebody would have devised a PDA, you could understand what could have happened. And this photograph I have pasted many times, right? But somehow it turns. This is a more recent story of last month. The patient was blue. You can see this is 10-ish-year-old girl, blue, cyanos and club. This is her XA ECG. So the residents picked up that echo was showing right to left ASD, and then they did a TR velocity. So TR velocity here is 40 only. So they say ASD with normal PA pressure. So they ran through the list, ASD with normal PA pressure and cyanosis, blah, 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 IVC to LA, RA, SVC going to LA, coronary sinus unroofing. What they missed was that in all of them, there is no cardiomegaly. Those lesions do not have cardiomegaly. When I examined the patient is in heart failure. So if the patient is in heart failure, you don't have to worry about LSVC opening or LSVC, RSVC. You do a repeat echo then shows, this is ARVD, you can see aneurysms of right ventricle, and LV function is also very poor. So the thing to recognize was that patient is in heart failure. The RV cardiomyopathy is worse than LV, and therefore there is a shunting from right to left. But otherwise, totally taken off as a cyanotic heart disease with AST and causes with normal PA pressure. But the real diagnosis was a cardiomyopathy right more than left, perhaps ARVD, but MR has not been done. But these aneurysms are quite like ARVD. I think it is ARVD with right and left both, but right more than left. This was a stump case. This is a neonate with a PAH. You can see the PA pressure. Heart is seemingly normal. PA pressures are in the range of 80s. You can see this heart again. PA pressure of 80 with this kind of heart, ASD right to left, little blue, bidirectional ASD, minimal blueness. So you will say, what is happening? And you see an echo, everything looks okay. And then you go back and examine again, and you realize the femoral is missing. And then you repeat echo, you realize there is a coarctation. So there are 2 things. Coarctation can sometimes give you much more pH than what you expect. You would think coarctation will give you left-right ASD, but sometimes coarct gives so much pH that ASD can become right to left also, peculiar. And unless you have put in, you see in real world, unless you generate a context, I did this echo and I thought, okay, coarct is not there. I saw that echo previously also, and I thought it's fine, you can see this. But again, when you do it with a little more mental commitment, you find there is a coarct. So this child had a coarct which presented as a pH. Few years ago, there was a man referred by some senior CTA surgeon that this patient is known to me and he has come, he has gone through all the CT and his hemoglobin is 21 gram. He has done his bone marrow and iron, and they have done all Cienka, Pienka, everything. But I don't know what is happening. And respectable hematologists had seen him. Somehow they missed that it was hemoglobin 21, but with a PO2 which is little low. So it was basically hypoxia-induced hemoglobin. They treated polycythemia and other things. And there is a history. And what is the history? The history is that he was operated for an ASD when he was 4-year age. And then it is easy. Within 5 minutes in the echo room, we did a contrast from the lower arm, and the IVC is going to LA, RA to LA, RA to LA, and the CT shows IVC to LA, and he was reoperated. So IVC to LA mistakenly, it is just, surgically when the eustachian valve is big, sometimes that can be mistaken as a atrial septum, and a good surgeon can sometimes be trapped. So this was it, and the patient was okay within next surgery. And this is the angio of that patient or another patient. We saw 2 such cases. Maybe this is the angio of another patient. This is courtesy Dr. Ramakrishna. You can see those who are not seen IVC injection filling left atrium because of a large eustachian valve stitched. Okay, a child with cardiomyopathy, poor LV function, usual cardiomyopathy type of things. All the peripheral pulses are okay. But I saw the echo, and the echo is showing a little bit of hypertrophy. Is it okay? Can I go on? So,
Please.
there is a LV hypertrophy, bit of hypertrophy on echo, and the diastolic pressure is 85 to 90 for a child. And I got a little suspicious. All the peripheral pulses are fine. The look is of a little bit of a chronic sickness. And you see the aortogram shows bilateral renal stenosis. This was aortoarteritis with a normal looking pulses. This is quite uncommon. But because we see so many of Takayasu children, we could still pick it up because the diastole was little high and the LV was little hypertrophic for a systolic dysfunction of that nature. So putting everything in perspective, putting everything in context, this is another renal artery stenosis, but this time it is not Takayasu because you can see this. This is the patient. So what does he have? Big cafeolar spot, and this is renal artery stenosis from neurofibromatosis. So all that is glitter, all that glitter is not gold. So this was neurofibromatosis, does not need steroids, need only renal artery stenosis. Well, if you are still not convinced, this is one of the fantastic case. This patient had a single ventricle. He was given a PA band. So after a PA band, you expect that he should be better. So after 6 months or 8 months of a PA band, he came, he is in gross failure. You can see this X-ray, and probably the only thing you can rule out is that CCP cannot look like this. Now patient has a single ventricle PA band, his RA is very large. There is no MRTR. Ventricle function is okay. And his JVP is up to the angle of mandible. I catheterized, the RA pressure is 20. So I had no other reason but to say that this is CCP. Post-operative CCP because of CABG induced, the post-cardiac surgery. So we took the patient back, the pericardium was stripped, cardiomegaly regressed, patient became better, and this is a pericardium thick. So this is a very rare case. Can you think of pericardium with this CCP, with this X-ray? But the context forced me to say this is CCP, so it was. And the patient improved and then subsequently went on the course of single ventricle. This is my Waterloo. This is a child with TAPVC. He was about 6 months old child. We say this is TAPVC, come for surgery. They say we have no money, will come after some time, arranging funds. This is the X-ray in May 2009. Oh my God, it's a long time has gone, but the story has never gone out of my mind. So this patient came after a month. Child is very distressed. And the mother says that he was okay, we are doing all right. So when a TAPVC comes with worsening of symptoms, what do you think? The PG should know that TAPVC is an ASD, and very commonly when the ASD becomes small with age, they come back with worse symptoms, more heart failure. Not with cyanosis, but more heart failure, because the ASD now is posing a restriction. More blood is not able to go to left heart, cardiac output is low. So I thought these villagers, they don't understand, they don't come in time, and the ASD must have become small. But to my surprise, the ASD was not small, and the lady was insisting that the baby was okay. I went to wash clothes, and when I came back, the child is distressed. I said, these poor people, they don't understand the distress, they often make a mistake. And she was insisting on her story. And I tried and look around the PA pressure, etc. Things were similar to what it was, more or less. And then you can see this X-ray, and any one of you, if you are there, if you can have, better eyes and minds in context, you can see this coin there. Mother has gone to wash clothes. Siblings, they were playing with coin, and the baby has put a coin in his mouth. And after this coin was taken, the TAPVC was not an issue at all. So this was a coin which has caused symptoms in a cardiac patient who came to me, and I looked for everything cardiac but could not find. I don't know how. Finally, we just zoomed on this, and so it is. So patients don't read books. Patients don't come with ready-made diagnosis we like. And so we have to be really worried, and we have to understand that this lady is telling truth. Suddenly there's deterioration, so let's look around. So this is what it is. And then I thought maybe the essay was there not previously. So when in May there was no coin, and when this came after a month, there's a coin, and we treated that. More recently, I saw this lady with Abernathy, and nowadays everybody talk of Abernathy because you can devise it. Patient has a PAH. So this lady had Abernathy and this funny kind of ear. And she had liver disease. And then another girl came. This is a different patient. They are looking so similar, and both have similar this thing. And she also, believe it or not, has Abernathy. So I have written this hemangioma. Should you see something like this, think of Abernathy in a proper context. This is new. I don't know how many will really hold on, but this is remarkable. So I just published it as a sign of Abernathy syndrome. You might say that, okay, over 20, 30 years, you can collect 10 such cases and try to talk about them. But what about day-to-day practice? But my friends, I think day-to-day practice is even worse in terms of cardiology, what is happening nowadays. You can see day in, day out, people, here is the case. Patient had a giddiness after PCI, a TMT, a Holter, a CT angio, MRI, carotid Doppler, renal Doppler, abdominal ultrasound, and all routine tests were done. And when you do tests, you will find something. So 70% lesion in right carotid, moderately positive TMT, 6 to 7 TSH, and a 2.5 second pause in Holter at night. What shall we do with this patient? 65, 70s. Now, can pre-syncope come from carotid? Time and again, we see carotid does not give syncope, but people will send carotid because there is some giddiness, some syncope. So this is out of equation. TMT following PCI could have some meaning, mostly doesn't. Hypothyroid is over-diagnosed, over-treated in terms of 6 and 10 TSH. Pause at night may be meaningless, but patient has some symptoms. So you can talk of history, and then you recognize that all things started after his PCI, when he was put on ticagrelor. And ticagrelor causes, it gives the sinus pauses, a little bit rare, but well-described cases are there. So you talk that antiplatelet drug, and the things are sorted out. A case report to this effect has been written in JAMA, published in JAMA case reports a long time ago. So this is from there. So you see everyday patient, and I'll tell you, patient comes for cholecystectomy, he comes for pre-operative clearance. Somebody does a TMT, then gets an angio or CT angio done, and that shows some calcific lesion. So you get a coronary angio done, he gets a TVD, patient gets surgery done. Now you put on DAPT, and the patient comes one day to casualty again, sir, I had a pain abdomen, I still have pain abdomen, but people have operated, his legs are swollen, his chest is tightened with a bandage. And what do you call that? Is that technology? Technology, high thinking technology, it's a high technology, low thinking things. If you want to do PCI, patient has hemoglobin of 9 grams, you say, okay, give blood tomorrow, let's finish it. Otherwise, the list will go on. And later on, patient has GI bleed after double antiplatelet and urine soup. Maybe. Aortic stenosis, becomes pregnant, gradient is 60. ACC, AHSA, severe AS is gradient 60. Do balloon, get an MTP done, get an AVR done. Nonsense. You didn't look into the patient. Patient was walking, he was class 1, he can go 4 flights of stairs. Nothing will happen to her pregnancy. So transfer all the guidelines, all the clinical knowledge with a context, with a clinical thinking. She does not need MTP, she does not need AVR. She just needs to get her pregnancy done, and we look after her later on. And you can go on multiplying stories and stories. And you see it every day yourself also. So don't you sometimes really feel that wish I was a doctor of that nature, where I can really practice what is important for my patient. And you can go back to this technology, if you can go back to the clinical evaluation with the patient. Remember, his story is never unimportant. His or her story is never unimportant. Observation will never be obsolete. Clinical thinking will never be irrelevant. Clinical thinking is the center that will restore the medicine to its rightful place, which is patient-centered medicine. So this is a heart failure patient, and you see every day in your clinic that a patient has heart failure, but he has associated thyroid and carotid and anemia and sleep apnea and GI bleed. He cannot afford your CRT. He has some creatinine of 2 and depression. So, put everything into it and then treat the patient. So may you all be a 360-degree cardiologist. Nowadays, you have 360-degree batsman. So may your cardiology range be 360-degree. But do not use this 360-degree thing to get more and more investigation done, to raise revenue for ourselves. And therefore, there is a lot of distrust between patient and us. We are also now distraught by the way people are dealing with us. Our distress is very, very expensive. Both parties are suffering. Society is suffering more than us, but we are also not liking this. We are practicing defensive medicine, all because there is a distrust. But I think the onus of restoring the distrust might well lie with us if we take it on our onus that, okay, we will practice the right medicine. Not because then you will say, my colleague is doing, if I don't do, he will do, and somebody else, he will go to somebody else. Damn those arguments. Let us practice what is right. And don't be parrot like 1, 2, 3, class 1A, B, C, ASCC, AHA. All kinds of guidelines are there. There are 568 guidelines for a common primary care physician. So let the guideline be there, learn from guidelines, use those certainly, but do not make them your master. Do not be rot parroting those things. Put clinical evolution in the center, put your patient in the center, know him, understand him. So if I can just wind up by reminding you this, that if you can keep your head when all about you are losing theirs and blaming it on you, if you can trust yourself when all men doubt you, but make allowance for their doubting too. If you can dream and not make dream your master, if you can think, but don't make thoughts only as your aim, if you can mint triumph and disaster and treat both of those imposters just the same, if you can talk with the crowd and keep your virtues or walk with the kings, but not lose the common touch, what is more, man, then you will be a man, my son. I wish you all the best. Thank you, Mohit. Thank you so much. Am I done? How much time? Oh, we have some time.
You are much earlier than that. Thank you so much, sir, for giving us a very practical and wonderful insight into the role of clinical evaluation. There is no doubt that, whatever and how advanced the technology is, whatever level of intelligence, whether it is artificial intelligence, machine learning, whatever algorithms we are prepared. But one thing that remains the truth is that prepared by us only. They're prepared by us human beings. So at any day, the human mind is the most superior and the most complex and the most sophisticated machinery that is available. The question is that we often spend our more time in designing the technologies to ease our life rather than brainstorming and putting our minds into the patient and actually getting the right diagnosis, as you very beautifully exemplified by some fantastic cases, that were mind-boggling for me personally, and I believe for almost 260 residents who are there online today with us. So it's absolutely terrific. I invite all our panelists who are all experienced in their own respects, to comment and, if there are any clarifications, to take forward the discussion. Dr. Tyagi sir, Dr. Sodai sir, Dr. Goswami sir, Dr. Suman sir, anyone.
So can I come in, Mohit?
Please go ahead, sir. It's all yours. Yeah, please.
Yeah. So I think it was wonderful, but I don't think we can exclude either. We have to use both. We have to use the clinical acumen, which is of course foremost, but technology also has given us many insights, So, you have an MI patient, anterior MI, you can look at his heart function, you can see whether he has an LV clot. So if you are catheterizing, you are aware of it, whether he had a pericardial effusion. So I think it's a mix of both, and we should not rely solely on one and use everything we have for the betterment of the patient. I think that's, and I agree, if you do not take a good history, if you do not do a clinical exam, you are not on the right track.
Absolutely. You see, technology, you cannot undermine technology. Technology has given everything, but pure pursuit of technology is what is happening. People in the name of technology are mishandling technology and really creating more investigations than needed, going just after technology. That is the point. Technology, without technology, we cannot practice medicine currently. Now we have reached an area where technology is very vital. Technology is the central, but then it should not be at the, should be a lopsided pursuit of technology. That's all.
I totally agree with you, sir, because the purpose of this holding this particular session, which is absolutely unique and a new topic, is to encourage our youngsters, our neurocardiologists who have been exposed more to technology and less to the clinical examination, that clinical examination still has a lot of relevance in picking up some diagnosis, and if you're missing something. So that is what complementing both is very, very important. Tyagi sir and Goswami sir, so there are any comments?
Technology is all right, but clinical examiners must to interpret the technology in proper sense. This is complementary to each other. We cannot isolate clinical exam from technology, or only technology forgetting the clinical examination. That is not good.
See, the one other thing which I forgot to tell about the patient's own, say, socioeconomic background. See, we do fantastic LMC stent. We put the patient on ticagrelor, and the patient goes out and he says he could not afford, so he stopped it, and he comes back with a SAT. And it happens so many times in at least our patient population. When you see it in the real world, so unmindfully the younger generation has not got it right, in the sense they don't keep the patient in center. You see. And we just see a patient has nothing to do. We say, okay, you need a CRT, you go home, get a CRT. And he knows that he cannot get a CRT done. So you introduce an element of fear in his mind. So you have to weigh your patient. If CRT is fantastic and CRT is life-changing, you know that. But if a patient is not able to afford CRT and you know there is no way he can get a CRT, telling him that you need a CRT is creating another disease for him. And we can spare that thought, for example. This is one of the parts. So everything is important, patient is important. And you must target therapy according to the patient.
My compliments to Dr. Kothari for such a wonderful presentation with his vast experience of more than 4 decades. Dr. Kothari has brought on many points on the clinical examination. But just to add, a human touch by a doctor is very reassuring to a patient, and many of the diseases and the problems of the patient can be solved by human touch. Another thing that we have seen commonly, many of the time patient comes with getting angiogram done, and clinical examination showed normal coronaries, but patient has chest pain, and just putting a stethoscope, we find that aortic stenosis murmur is there, which has been not been diagnosed aortic stenosis. Such examples have been seen in the many other clinical scenarios also. Besides that, the clinical examination helps to restrict the number of investigations that are required to clinch the diagnosis in many situations. So clinical examination is and would always remain at the foremost, along with the history taking, sympathetic listening to the patient. It helps to cure the patient many of the times, and helps us to understand the problems of the patient, which may not be physical, but often may be psychologically induced also. Compliments to Dr. Kothari for a nice presentation.
There's no doubt. And, Kothari sir, I would like to say another very beautiful thing now. Your presentation today reminds us of a very interesting case, because it was few years back, we had operated a case, and patient was stented for left circumflex artery. And another couple of weeks later, patient presented with a complete heart block without any chest pain, and the patient was evaluated, everything was fine. And ultimately it was decided to, do a pacemaker on the patient. But then one of our fine residents decided to interrogate the patient deeply, and you would be surprised that when we interrogated the patient and took a deeper history, the patient was a case of a bipolar disorder, which was missed earlier. Nobody investigates, and he was on long-term lithium therapy. So what happens? Lithium therapy was already there, but after the PCI, he was already put on ACE inhibitor. Now, ACE inhibitors with lithium therapy, it significantly elevates the level of lithium, and that was the cause of his particular block. So when we stopped that particular thing, everything recovered, and he was saved from a pacemaker. So no doubt, evaluating the patient, we published this report ultimately, but evaluating the patient, talking to the patient, spending a few minutes with the patient, my colleague Girish would agree that, it often saves a lot of catastrophe that, you can actually land up into. So no doubt, clinical examination, spending time, each patient has a story behind it. It needs to be listened and devoted time by the doctor to the patient. Girish, any comments from your side? So this,
that was a wonderful talk, sir. It was really one of the best talks I've ever heard in my entire career. I would totally agree with you that you should both the things are complementary to each other, and you should treat the patient rather than the report. That is what I usually say to my resident fellows also. And most of the times, even ours being a referral center, sir, you would agree that most of the patients just come and no, just throw their reports in front of you and say everything is there in that and you treat. So I politely say, you tell your problem, let me examine you first and then go ahead with the reports and all. So that definitely saves from a lot of things like Kothari sir gave a beautiful example of cholecystectomy. But I have seen patients of cataract coming for some ECG changes and ultimately getting a angio done and PCI done, and subsequently the surgeon is not doing anything for his cataract. Ophthalmologist is not doing anything for his cataract. So ultimately, what you have done is actually worsen the patient's problems rather than doing any good. And more so, as you all know, that foreign body is a foreign body, and you never know about the treatment, what the patient is going to take continuously or intermittently, or misses drugs, which might lead to a catastrophe.
Hope everybody has contributed. Hope.
Just one little remark. I think many of the people who are on panel are in a generation where physical examination is still important to them. How do you inculcate this behavior change in the younger people? I'll give you an example, because recently, 4 years ago, I was after a PCI of 2 vessel. The patient was saying, I'm not still well, I just auscultated. And what we discovered was a VSD, which happened 4-5 days after the MI. And he was a recent MI and needed primary and then another vessel angioplasty 2 days later. And none of the residents had auscultated or even decided to talk to the patient. So, but how do you inculcate in the youngsters this important tool of physical examination, of history taking? Because for them, it is only echo and ECG and that's it.
Yeah, it's a real.
Can
It's a real
I
problem.
contribute? Yeah, sorry.
Yeah, I just thought this is a very important problem actually, and what we are seeing more and more, they are not convinced even that it is needed. So one of the senior cardiologists one day remarked that the only thing that people tell me on round is that, sir, he's ready for angio. There's no other thing about that particular patient, and it's a very you can see the younger generation is not really even believing, because the technology is so powerful that most of the time we are getting away even without knowing the patient. We see there is a problem and we treat that problem. But I think we have to insist that we need to put the focus back. I think so. Yeah, Dr. Sudhir Kumar, please, sir.
Okay, I think it's a wonderful talk. Appreciate Dr. Kothari's talk, because he's done all the wonderful investigation. But what he was trying to highlight is, in problem cases where we have done all the things, at least go back to the patient history and physical examination. That's a number one message. Among the various things, apart from the investigation, I give too much significance. I think we have to give extra importance to the history, because we have been taught that the patient is coming to us to give us the diagnosis. We refuse to accept that. So just to listen to them. And I'm sure that is more important than probably all the things we ask in the examination to students about JVP, what is AV, what is CV, everything is important. But I give more importance to the history, followed by a simple routine clinical examination and baseline investigation like that. That stepwise approach is important. Then certain instances where I have found the problems are, one is anemia. Many patients come with anemia. I have seen large number of patients taken up for coronary angiogram normal, and going back it is anemia. This is one of the common things which I have seen. That is one thing. Second is, as discussed earlier, preoperative evaluation. That is one area where I have found the patient comes with a problem. We take the patient for an inactive problem, and the patient has come for surgery that is delayed or deferred. So our approach should be to see how the patient's problem can be sorted out first. The priority for the patient should be given importance rather than our priority. As I know over the years what have happened. I started my career about 50 years back. At that time, patient was important. Now we are more important. We used to deliver what the patient needed. Now we deliver what we have with us. Things go like that. And regarding the students, I think the students learn from us. So we can't blame the students. I never blame the students, because the students learn from the teachers or the seniors. We have peer role models. Not that we should go away from the investigation. My approach will be a detailed history, examining the patient by looking at him rather than sitting in the computer and writing. Seldom we look at the patient. Face-to-face contact is very important. Touch the patient. Half of the things are over. So good patient, family, doctor relation. For that, history, physical examination is important. More important than the diagnosis. You touch the patient, you see the patient, you smile at the patient. Don't frighten the patient, pacify the patient, just like ICD or some CRT. You study whether the patient is willing for that. If the patient is not willing for that, I'll tell you one example. Why in our state, even other states also, many patients are going to the alternative system of medicine. Now, the problem is a patient comes to us, the patient has some chest pain, the patient is being evaluated, underwent coronary angiogram, he is advised surgery, but the patient is not willing for surgery. So we tell that we have these 3 lesions, it is this thing, his mortality is this much, all those things. So we have to go for surgery. He is not willing for that. So he goes to X, another colleague. He also tells the same thing. Then he'll think, why I should consult a modern medicine doctor. Now there is an alternative system person there. He goes there and he says, I will do everything for you, because he learned that this patient is not willing for surgery. And we know that surgery benefits only an additional 10 or 15% of patients. So 50 to 60% patients will improve. So he says that I can manage you. You will be comfortable. That is enough for symptomatic improvement. Because my first aim is quality of life, not the quantity of life. I don't want to live for an extra 6 months at the age of 75 years. But if I am surviving for 2 years or 5 years, I should be comfortable, I should be happy. So treat or see what the patient needs and deliver what the patient needs with all our recommendations, all those things. Even the preamble in the recommendations is very clear that this is not a Bible. This is a guideline. It should be applied based on the clinical situation. Thank you, Dr. Mohit, for giving us the opportunity to share the platform with wonderful people, especially hearing the Dr. Kothari's talk, which combines both. That is a high academic thing, plus the simple bedside history, everything. A great, sir. Thank you so much.
Thank you. Thank you so much. Any other comments? If there are none, no. So I think congratulate, sir. And
Can I share my experience?
Please go ahead, Girish. Please.
Sir, this is during my MD days. So I had one patient who had come with ventricular fibrillation. He was cardioverted and he was doing all right. He had multiple episodes rather. So we had a tough time in managing him. So once he became conscious and I personally went and I asked him the history. So since the first time when I saw him, he was I had to do a CPR. So after reviving, I just had a detailed history with him. He was an Ayurvedic physician, but not a trained one. Self-declared Ayurvedic physician, practicing in a village. So it went like this, that some of the patients who we had treated of late had some nausea, vomiting and other things. So what he did was, he was not happy to listen to such comments from his fellow villagers. So what he did was, whatever the preparation was, he just consumed that and he had come with cardiac arrest. So when we asked him, please get all your ingredients. So he asked his son to get all those things. And we found out that he was using aconite there, which is a known cardiotoxin. So that actually told us that it was a reversible sort of ventricular tachyarrhythmias, and he would not require a permanent medications or maybe for that matter any other investigation after that. So after stopping all those things, he understood what we told, and he was happy that we showed the culprit what was the reason for his problem and his villagers' problem. I think he had stopped using that subsequently. He did well for the next 1 year, and after that, he didn't come to us.
The absence of that
Great.
story, we would have said secondary prophylaxis, class 1 indication, he needs an ICD. So you
Yes.
absolutely, sir. No, this is the point. Just one thing, Mohit, I would like to say, if people are listening, the younger generation, that there's a tendency to frighten the patient. It is more and more becoming so digitized. They are now digitized. What children, as Dr. Bhandari says, nobody is able to teach how to teach them. The tendency is them is to just translate what is there in the books and say this is what this is mortality, this much, this is this thing. So there is a disconnect. They talk to patient as if they are talking to a machine, and I'm seeing more and more, no empathy, no concern, just a work, just a job like attitude, which is draining more and more, and that is creating more distrust. And I think at least the minimum you can do, see, our patient population largely is very different. Some are very affording, some are, a large segment is not affording. So those not affording patients don't create more distress by quoting some things and scaring them and telling them things which are not actually possible. Just as a thought. Yeah. Right.
Well,
Thank you so much.
Thank you, everybody. Thank you so much, sir. Thank you, sir. Thank you, Sudhir sir, Goswami sir, Rakesh sir. Thank you, Bhandari sir. Thank you, my colleague, Dr. Girish. Thank you so much, Dr. Tyagi sir, for this wonderful discussion today. And gratitude to all of you, and gratitude also to our interns who have provided us this platform for over the last 2 years. And thank you for all the fellows and residents. There has not been a single session we have not had an attendance more than 200, 300 plus. This is really good. This only shows, and to be very honest, there's a 100 session was only because of it's after a 1 month gap that you people were repeatedly asking us to restart this. And thank you for all the motivations. I think there are no barriers to academics, and COVID has taken it to a next level. And we will catch up again with another session, 101th webinar, and we'll continue our academics. We promise you to bring the best in the country and probably some of the best in the world also. And in case you have any suggestions and comments, please write to us personally on the PG Track CSI Delhi branch at gmail.com. All our lectures by the experts are loaded free of cost on the YouTube. You can download them, you can read them, you can reread them, re-listen to them, and enjoy your academics. Thank you so much again, and goodbye. Have a safe time. Happy Diwali to all of you.
And Mohit, yes, sir, congratulations.
Thank you so much.
Congratulations to team CSA Delhi chapter, especially Mohit, and team Intas, Mudit, and Amit, for actually giving us a lot of support, and all the people who have been, all the teachers who have been part of this wonderful journey.
Thank you. Thank you so much. Thank you. Goodbye. Thank you. Bye.